This conference will now be recorded.
Okay, excellent. So guys, today is week 8. All right, week 8. Remember, we skipped week 6 because Rankin is going to go over all of that information with us. So today we're going to be covering chapter 120, which is infectious disease disasters, bioterrorism, emerging infections, and pandemics, and then a bit of chapter 34, which is intravascular device infections. I actually wanted to do a deeper dive into intravascular device infections, and I think I'm probably going to do a bonus lecture on that because I want to ask my vascular access services coordinator to put together a presentation, like collaborating with both VAS and IP to present to you guys. So we'll cover some stuff today, but I have something like in my mind in the works that I want to try to do because I think it would be really great to get a different perspective. Dave is our VAS coordinator and he's also VABC. So he was actually really instrumental to me passing my test because he was the person that I shadowed a lot and that I learned from a lot, as well as Lily, who she's no longer in our campus. She actually transitioned out and went over to industry. So, okay, so week 8 readings is chapter 5, infection prevention and behavioral interventions, chapter 34, which is intravascular device infections, and chapter 120, which is infectious disease disasters, bioterrorism, emerging infections, and pandemics. And then you can see week 9. Week 9, all of those chapters, you have to read every single one. There is no not reading any of them. Every single chapter for week 9 has to be read. All of those chapters are important for the test. I felt personally when I was preparing for my CIC exam that the blue book, um, Charles, did you use the hard copies to study or yeah? Which book did you feel was the most useful? I would say the blue book, right? The first 20 something chapters. The first, so Charles is one of our IPs here. He's a nurse and he has his CIC. He's currently doing his MSN. So it's really, really, we're very excited for him in the department. And so, yes, we will um, we will definitely recommend that you read those chapters. Okay, so chapter 120, which is infectious disease disasters, bioterrorism, emerging infections, and pandemics. So I was watching a TED Talk the other night, and this TED Talk came up as a recommendation, which is My Wish, Help Me Stop Pandemics, which was done by Dr. Larry Brilliant in February of 2006. And this TED Talk was really great. I really enjoyed watching it. It was talking a lot about early detection systems and how important early detection is for the prevention of pandemics. And this is one of the things that I really, really try to emphasize when I'm speaking specifically to my leadership on the campus. It's the department, the department is infection prevention for a reason, right? So infection prevention means that we're trying to focus on preventing as much as we can. So if you have an infection prevention department that doesn't have adequate staffing, where you're extremely overworked, you have a ton of units, a ton of assignments, and all you're doing is trying to put out fires continuously, where are your prevention efforts going to really come in? And so those are some of the things that I really try to make sure that I emphasize when I'm meeting with my leadership, and something that I think we all need to try to emphasize when we're talking about our infection prevention departments, our hospitals, is helping them understand the importance of focusing on prevention, because we can't just continuously be putting fires out. It's too much work. And it's not that it's too much work, but it's not what keeps us safe, right? And so in this lecture, you really get to see, his emphasis on early detection, and he talks about the SARS epidemic, and he specifically talks about GFIN, which is the Global Public Health Intelligence Network, which was started in Canada and worked closely with the WHO. And it was basically one of the most important surveillance systems that was reporting a lot of what was going on. It was sending out a lot of alerts when it was first, initiated. So it was created back in 1994 as a way to improve Canada's intelligence surrounding outbreaks. And they were really instrumental in the identification of the 2003 SARS outbreak. Um, And it really highlights the importance of that early detection. One thing that was really important because, as I'm listening to this lecture and I'm learning about GFIN and going back to it and reading more about it because I can't help but want to know more, it was really interesting because when you look at the 2019 and 2020, they wanted to have a more domestic focus. Canada wanted to have a more domestic focus, which, like, let's talk about it. It should not be all on Canada, but they wanted to have a more domestic focus. And so they started assigning their employees to different tasks. So the shutdown was really gradual and over time. In 2009, there were 877 alerts. There were 198 in 2013 and only 21 alerts in 2018. And the final alert, so the last alert the system sent out was on May 24th of 2019, right before the COVID pandemic. So I can't, there is no way that we can stress the importance of strong surveillance systems, right? We have to take surveillance very, very seriously. And early detection is key, right? So if we're coming in at the peak of an outbreak or at the peak of an issue, how are we really going to be able to control it? How are we really going to be able to, prevent widespread disease? And so the story, right? The point to the story is early detection is extremely important. So let's talk about bioterrorism. So bioterrorism dates back to the 14th century when cadavers were dropped into enemy wells to poison the drinking water. I remember my professor, is it guns, metal and steel, or guns, bugs and steel? Which one is Guns, Germs, and Steel? Thank you. Yeah, when he was talking, I gotta love my people because they're in the office and they're like, come on, Luz, you gotta know this. When he was talking to us about all of the different strategies that have been used with, infectious diseases in the past and in history, and it's just really fascinating stuff. But it does date back to a very long time ago. Another example of bioterrorism occurred during the French and Indian War when Native Americans were given smallpox-laden blankets, right? Because we know that smallpox can live on articles of like clothing. This action is believed to have initiated smallpox in this previously unexposed population and resulted in a 40% mortality rate, which is an extremely high mortality rate. In the previous lecture that I was talking to you about, the one that Larry Brilliant did, he also goes into detail about smallpox a lot, about the work that he did and that different organizations did to really focus on eradicating smallpox. Um, in 1984, we had the Rationale bioterror attack, and that was when food poisoning of 751 individuals in the Dalles in Oregon happened, where they deliberately contaminated salad bars at 10 local restaurants with salmonella. And what this group was hoping to do was they were hoping to incapacitate the voting population of the city so that their own candidates would win the 1984 Wasco County elections. And the incident was the first and single largest bioterrorist attack in the United States history. The 2001 anthrax bioterrorism attack, which we're all very familiar with, caused 22 cases of anthrax and 5 deaths. It required over 10,000 doses of post-exposure prophy to be distributed and cost more than 2.5 billion, yet was essentially a small event involving only the use of 2 to 3 ounces of anthrax spores. So bioterrorism attacks they're very serious. So, infectious disease disasters. Infectious disease disasters are events that involve a biological agent or disease and that result in mass casualties, such as a bioterrorism attack, a pandemic, or an outbreak of an emerging infectious disease. Infectious disease disasters are different from other types of disasters because they increase the risk of communicable disease spread during and after the incident. They involve the need for specialized mitigation, planning, and response intervention to prevent and control the spread of disease. You've got multi-departmental and multi-agency endeavor that encompasses the 4 principles of emergency management, which is mitigation, preparedness, response, and recovery. So as an infection preventionist, you should be involved in your emergency response management. When a command center gets activated, right? IP should be at the table. We have our own little vest, and it says infection prevention on it for when the command centers get activated. And so, please, 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 please make sure that you have those connections within your department and within your facility. And then that circle expands, right? You have to know who are your partners in public health. Who is it that you're going to reach out to when there's this type of event. I remember when I was working at the health department, there was this really great event that was put on by like law enforcement where they talked to us about different sorts of, bioterrorism attacks, the importance of, communicating with all of the different emergency response teams, and ensuring that you have a cohesive response, which is important for us to have drills, right? So we already had a drill earlier this year, within our county. It was multiple counties actually. It was more of a region drill. It involved three of our largest counties in Central Florida. So it's important that this work is happening. Some common characteristics of bioterrorism agents is the ability to be dispersed in aerosols of 1 to 5 micron sized particles, which can penetrate the distal bronchioles, the ability to deliver these aerosols with very simple technology, the feasibility of these agents, if delivered from a line source like an airplane upwind from the target, to infect large numbers of the population, and the ability to spread infection, disease, panic, and fear. It just sounds, yeah, it it sounds exactly exactly how horrible it would really be. Methods of dissemination. So the most likely route of dissemination is an aerosolized release of 1 to 5 micron particles. Other methods of dissemination include oral, such as intentional contamination of food or water supply, like that outbreak that we talked about where they contaminated all the salad bars with salmonella. Percutaneous or infected animal vector, like the release of infected fleas, and obviously human to human spread, which is individual infected people with communicable disease walking among a crowd of healthy people. As the anthrax attacks of 2001 proved, even physical objects such as letters can be used to help spread biological agents. Some key concepts. Infectious diseases continuously emerge and or reemerge, resulting in epidemics of varying sizes and scope. And I think that this is probably one of the areas where I personally feel like as an IP, I could be doing a better job as. So what I have found is once you enter the world of infection prevention and you're in the hospital, you have so many demands within your facility, right? You've got this little world, this little bubble of patient care activities, this facility, however large or small you are, that you are now responsible for and that you're constantly helping. And what I have found is that, um, you know, sometimes it's difficult to seek out, okay, well, what is the latest research saying on what is happening with emerging infectious diseases in other areas, in other places. I'm so worried about trying to decrease CLABSI and CAUTI rates that it's like, oh well, there's another emerging infectious disease, oh my goodness, what am I like, you know what are we going to do now? Like it's difficult. And so I think part of being a good infection preventionist is realizing what areas of information you're lacking in, and trying to increase them. So yeah, I think this is definitely an area that maybe not just me, maybe other IPs could really be focusing on, is broadening that awareness of what's going on a global scale. Pandemics pose the biggest potential threat to the public's health in terms of morbidity and mortality, and there is a high likelihood of a pandemic occurring in the future. Hello, we are. Yes, of course. Infection preventionists must undertake preparedness activities to ensure that they and their healthcare facilities and communities are better prepared to effectively recognize and respond to an infectious disease disaster. Infectious disease disaster preparedness is an ever-evolving process that addresses the four principles of emergency management, which are mitigation, preparedness, response, and recovery. Okay, so let's go over bioterrorism versus biological warfare. So, what is the difference between bioterrorism and biological warfare? What is bioterrorism? You can write it in the chat. It's small enough of a group. If you want to come off mute, you can. Okay, I haven't gotten any answers yet. Oh, okay. So biological warfare only directed to Airy persons? Okay. Army. Okay. I should have added the M in my head. Yeah, so with bioterrorism, it's the intentional use of a biological agent or derivative of such an agent to inflict harm or death onto a civilian population. Biological warfare differs from bioterrorism in that the target of the attack is military personnel. Again, you're going to have some questions that are very straightforward. With this one, you have to just remember your definitions. Because it could give you different examples of the following attacks happened, give you the example of the salmonella in a salad bar, or, anthrax being disseminated at a, you know, military facility, whatever, which of the following is an example of biological warfare. And then you would have to determine. Bioterrorism preparedness. Bioterrorism preparedness helps mitigate potential negative outcomes and is required by healthcare and public health regulating agencies as part of a comprehensive emergency management team. The future potential impact of bioterrorism depends on the agent used, the amount disseminated, the dispersal method, and weather release conditions, the pre-existing immunity of the exposed population, and how quickly the attack is identified. So again, early detection. It keeps popping up. It, the the early detection, really keeps popping up, and I think it's extremely important. So when we start breaking down our different types of categories, so categories, the one that's going to have, it's going to pose the highest risk to national security. And these are some of the reasons why. They can be easily disseminated or transmitted from person to person. They result in high mortality rates. They have the potential to cause public panic and social disruption, and they require special preparedness actions. Okay, so pose the highest risk to the national security, and these are some of the reasons. Now, some of those examples of category A, it's going to be important for you to remember to the best of your abilities what category these diseases fall under, whether it's going to be A or B or C. So, for category A, you've got anthrax, botulism, Yersinia pestis, smallpox, tularemia, and your viral hemorrhagic fevers, like Ebola or Marburg. For category B, this is going to pose the second highest risk because they are moderately easy to disseminate. They result in low mortality rates. They require an enhancement of diagnostic and surveillance capability. Some examples will be West Nile virus, caliciviruses, hepatitis A, ricin toxin, salmonella, diarrhea E. coli. Okay, and category C. These are emerging pathogens that could be engineered for mass dissemination because they are available, are easily produced and disseminated, and have the potential for high mortality rates. And this is going to be influenza, SARS, rabies, multi-drug resistant tuberculosis, yellow fever, and tick-borne hemorrhagic fevers. Now, that chart I like better than the one that the APIC text provides because I like that this chart gives you like definitions and that it's telling you like this poses the highest risk. These are some reason why, and these are some of the examples. But for your for the test, just make sure that they're very similar. Just make sure that you're following the organisms that they have listed in this table. Okay, so for category A, you're going to have your anthrax, which is Bacillus anthracis, your botulism, plague, smallpox, tularemia, and your viral hemorrhagic fevers. For category B, it's a bit of a longer list, but you've got your brucellosis, epsilon toxin of Clostridium perfringens, food safety threats like Salmonella species, E. coli 0157H7, Shigella. You've got glanders, which is Burkholderia mallei, melioidosis, which is Burkholderia pseudomallei, psittacosis, which is Chlamydia psittaci, Q fever, Coxiella burnetii, ricin toxin from Ricinus communis, which is from castor beans, and then staphylococcal enterotoxin B, typhus fever, viral encephalitis, and then water safety threats like Vibrio, cholera, Cryptosporidium parvum, etc. And then you've got your category C, which is going to be your emerging infectious diseases such as Nipah virus and Hantavirus, and these were adapted from CDC. Okay, so true or false? Of all types of infectious disease disasters, epidemics pose the biggest potential threat to the public's health in terms of morbidity and mortality. Is this true or false? Okay, I've only got one answer. It's okay if you're not sure. You can just guess. Okay, Cindy put false. Good job, Cindy. It is false. So we just read the potential impact of a future pandemic is staggering, and the pandemics are really what's going to pose our biggest potential threat to the public's health in terms of morbidity and mortality. Cindy said that was a guess. Okay. Well, I mean, where did we go over it? Right here. Key concepts. Pandemics pose the biggest potential threat to the public's health in terms of morbidity and mortality, and there is a high likelihood of a pandemic occurring in the future. Okay. So, like this one was saying, the potential impact of a future pandemic is staggering. It has been estimated that an influenza pandemic could infect approximately 30% of the US citizens, about 90 million individuals, require the need for 45 million additional outpatient visits to healthcare agencies, and 865,000 to 9 million hospitalizations. So we really got to experience, the 6 phases of a pandemic recently, right? So let's go ahead and try to go through this. So you've got different options here. You've got options A, B, C, D, E, and F. And all of these represent different phases of a pandemic. So what I want you to do is I want you to read through some of these options, and then you're going to tell me which letter you think is phase number 1. Okay, I have one person saying D. Somebody else is saying E. Okay, so let's do number 1. Okay, so number 1, phase 1 is a low risk of human cases. All right, what about number 2? Phase number 2. So phase 1 is low risk of human cases. What would phase 2 be? Okay, phase 2 is higher risk of human cases. All right, what about phase 3? Okay, Kia said D. Very good. So we've got low risk of human cases to higher risk of human cases. And number 3 is no or very limited human to human transmission. So what is going to be phase number 4? Good job. C is correct. We've got 2 left. So which one's going to be number 5? Very good. So we've got our 6 phases here. So 1 is our low risk of human cases, right? Then we've got our higher risk of human cases, which is 2. No or very limited human to human transmission, which is where we've got that pandemic alert, new virus causes human cases. You've got that evidence of human to human transmission. 5 is that evidence of significant human-to-human transmission, and then 6 is efficient and sustained human-to-human transmission. Okay, which of the following bioterrorism agents has the highest fatality rate? So you've got Q fever. A is Q fever, B is ricin, C is smallpox, and D is severe acute respiratory syndrome. Okay, so it looks like our options are primarily between C or D, so either smallpox or severe acute respiratory syndrome. So there are going to be a lot of times on the test when they're going to ask you questions about, statistics or fatality rates or other values that you're not going to be able to immediately pull from your head. Right? So it doesn't matter what day of the week it is. I'm not going to be able to tell you the fatality rate for these diseases off the top of my head. Okay. It's going to be a difficult thing for me to remember. Number one, because I'm really bad at math. Number two, because there's so much other stuff up in my head that like this is going to get lost. This is going to get filed away somewhere and I'm not going to remember it for an exam. So when you're feeling like I don't know how to even start to unravel this situation, number one, don't spend too much time on it because you still have a bunch of other questions that you're responsible for answering. But number two, try to be strategic with your planning. So we have already looked at the fact that we've got all of these organisms that we're working with, right? All of these organisms that we are looking at and we're trying to find what has the highest fatality rate. Okay, well, what do I know? I know that organisms, when it comes to bioterrorism agents, can get split into separate categories, category A, B, and C. And we know from our previous chart that, right, from our previous chart that category A poses the highest risk to national security because they can be easily disseminated, person to person, result in high mortality rates, and have the potential to cause public panic and social disruption. Okay, for B, they can result in low mortality rates. And for C, they have the potential for high mortality rates. But category A, they're the ones that like, yeah. These result in high mortality rates. So what you can do is when you're taking a look at a question like this, is break it down to, it's breaking down, okay, well, which ones are going to be category A? Which ones are category B? Which ones are category C? You have to know your categories. And smallpox is the correct answer. When we look at the rationale, smallpox is an acute, contagious, and sometimes fatal disease caused by the variola virus and marked by fever and a distinctive progressive skin rash. The majority of patients with smallpox recover, but death may occur in up to 30% of cases. Bioterrorism agents can be separated into 3 categories depending on how easily they can be spread and the severity of illness or death they cause. So, um, find a way, right? Where there's a will, there's a way. Find a way, ask yourself, what do I know? How can I try to figure out what the correct answer is for this question? Question number 2. You have been notified that a possible smallpox patient has been identified in your community. The patient is being admitted directly to your facility. What type of precautions should your personnel take when caring for this patient? A, airborne isolation with negative pressure ventilation. B, resistant organism precautions. C, airborne isolation with positive pressure ventilation. Or D, droplet precautions. Very good. Everybody put A. Yes, we're going to do our airborne isolation with negative pressure ventilation. So, you know, again, whenever you have these types of questions, we have certain jargon in IP, right? We've got what? We have droplet isolation, contact isolation, enteric, isolation, depending on your facility. Do some facilities probably have a specific multi-drug resistant organism isolation? Yeah, but when you look at the primary ways that people get split up, it's droplet, contact, airborne, and then you may have that enteric for those C. diff patients, those spores. Um, so I would immediately cross off resistant organism precautions because it's not a term that we're commonly familiar with. We know about multi-drug resistant organisms, but when it comes to isolation, I wouldn't call my unit and be like, hey, put that patient on resistant organism precautions. I would be like, hey, please place that patient on contact precautions. Airborne isolation with positive pressure ventilation. This comes into us knowing how the HVAC systems work and what the purpose of being in a negative pressure room is. It's about those exhausts. It's about those air exchanges. If we've got that positive pressure, we're pushing out whatever is in that room into our other areas. That's not what we're looking to do. We're looking for those 12 air exchanges per hour. We're looking for that negative pressure where it's being, exhausted outside of the building. Like all of these things are very important. And so you would be able to, at minimum, break it down to it's either A or D. Okay. Um, so airborne isolation with negative pressure. Okay, I need to speed up. Okay, so question number 3. Infection prevention and control priorities in a disaster include all of the following except A is sterilization of instruments and disinfection of equipment. B is obtaining medication from vendors not affected by disaster. C is maintaining the ability to prepare food for employees and victims. Or D, drinking water for employees and its victims. So all of these are infection prevention related activities, but priorities, except one of them. Okay, very good. For those of you who put B, obtaining medication from vendors not affected by the disaster. Just think about during COVID, right? When we started run out of certain meds, or when we needed to consider substituting, when there were issues with supplies, who was notifying you of those issues and who was trying to solve those issues? It was our pharmacy. It was our pharmacy leaders. It was our system pharmacy. It was our pharmacist who was providing us with the updates. The state is allotting X amount of monoclonal antibodies. This is what's happening. We're having issues with this. We're running into a shortage with that. I mean, I wouldn't know where to even start, to be completely honest. Um, and some of these questions make a lot more sense now that I've been in the role for some time, because it's like, oh no, they're totally right. Like this makes perfect sense. So obtaining medication from vendors not affected by a disaster, emergency management of infectious disease disasters is a multi-departmental and multi-agency endeavor. In most situations, chemoprophylaxis will be important during an infectious disease disaster. The healthcare facility's pharmacy department should be instrumental in preparing for disasters by stockpiling medication or making arrangements to obtain additional supplies. In the event that local resources are exceeded by need during a large-scale infectious disease disaster, medications and supplies can be obtained from the CDC Strategic National Stockpile. We're not even going to do that. We're not even going to talk about that today. So question 4. Of all the common types of agents used for bioterrorism, one type is primarily transmitted to others by contaminated food and water. Which type is that? You've got A, tularemia, B, cholera, C, Q fever, and D, anthrax. Okay, lots of people put B, cholera. Right, so you've got our category. So tularemia is a category A, cholera is a category B, Q fever is a category B, and then anthrax is a category A. So cholera is an acute diarrheal illness caused by infection of the intestine with the bacterium Vibrio cholerae. The infection is often mild or without symptoms, but can sometimes be severe. Approximately 1 in 20 or 5% of infected persons will have severe disease characterized by profuse watery diarrhea, vomiting, and leg cramps. In these people, rapid loss of body fluids leads to dehydration and shock. Without treatment, death can occur within hours. cholera is a category B bioterrorism agent, which are moderately easy to disseminate, result in moderate morbidity rates and low mortality rates, and require specific enhancements of CDC's diagnostic capacity and enhanced disease surveillance. All right, question 5. Which of the following infectious disease disasters pose the biggest potential threat to the public's health in terms of morbidity and mortality? And you've got option A, which is epidemic, B, which is emerging infections, C, which is biological warfare, D, which is bioterrorism, or E, which is a pandemic. Okay, yes, we definitely got it on this one. We got the pandemic on this one. Um, okay, so of all types of infectious disease disasters, pandemics pose the biggest potential threat to the public's health in terms of morbidity and mortality. As experts in the fields of communicable diseases, infection prevention, and epidemiology, infection preventionists are poised to be at the forefront during an infectious disease disaster. As such, IPs must embrace their role as experts in infectious disease emergency management and assist their healthcare facility or community in becoming better prepared to rapidly, appropriately, and effectively respond to an infectious disease disaster. And talking about response, there is a center out in Alabama. Somebody tell me what the name is. It's the Center for, what is it? Domestic something. Alabama. Sorry, I'm trying to Google. But there's an actual center out in Alabama that focuses on disaster preparedness and training. So they've got all of these different classes, or it's not classes, it's trainings, courses that you can go do at this training facility that focuses on like putting PPE appropriately, disaster response, bioterrorism. I need to. Is it a? It's why do I feel like it has a C, a D, and a T? Like Center for Domestic I don't know, training. Anyway, I will look for the name for it. But if you guys can find it, oh, is it CEP, the Centers for Emergency Preparedness? Is that what it is? I couldn't. My internet's not working in here, per usual. But okay, so that's an option that you have. That's something that you can talk about because that you can look into to obtain that training, right? So if those trainings aren't available to you locally, then potentially this is something that you need to talk to your leadership about having the opportunity of doing. It's actually one of the things. Oh, okay. So it's we think it's the Centers for Disaster Healthcare Preparedness, CDHP. That sounds like that could be it. Cindy. You're probably correct. Google to the rescue. Yes, that sounds exactly like what it probably is. The Center for Disaster Healthcare Preparedness, CDHP. And they have trainings and you can go out there and they train you. I know one of my colleagues who went out to one of their trainings and she really, really enjoyed it and she found it super, super useful and super beneficial. So just as a consideration. Okay, true or false? Quarantine is the separation of individuals who are symptomatic and have been exposed to a contagious person. Is this true or false? Quarantine is the separation of individuals who are symptomatic and have been exposed to a contagious person. Okay, so I have a lot of people saying true, but I've got two people saying false, which is Maria and Kia. Maria or Kia, do either of you want to say why you think this is false? Okay, so what they wrote down is asymptomatic because they are already symptomatic. Okay, so that's going to make sense in just a second. So it's false. Okay, quarantine is the separation of individuals who are not yet symptomatic but have been exposed to a contagious person and are believed to be at risk of developing an infection. These exposed individuals are quarantined or separated from others as a way to rapidly identify onset of illness if it occurs and to keep them away from susceptible people. Once a person in quarantine develops signs or symptoms of disease, it would be assumed that they are infected and they would need to be isolated. And the person who really solidified this definition into my head was my old epi manager, Alvina Chu. I remember I was having a conversation about something that was going on. And for some reason, I said, yeah, so this person needs to be quarantined. And she was like, no, no, that's incorrect. The person needs to be isolated. And I was like, no, but they're like the same thing. And she was like, no, no, they are not the same thing. And I remember she like sat me down, she talked to me about it, she explained it. She was like, these are the differences. Like, the vocabulary that you choose to use is really important because it has specific definitions, right? And so again, this is one of those definitions that you have to know because they could provide you an example and say which of the following is an example of quarantine or of isolation, etc. And so knowing the difference between quarantine and isolation is really important. But yeah, I will always remember this because of Alvina. I remember I was like, "Oh no, Alvina's for real, for real. Like this is serious." I'm gonna remember the difference between quarantine and isolation. And sometimes it just takes that one person that is able to explain something to you or help you understand something. So remember that you may be that person for someone else. Okay. Let's see. We're at 47. So why don't we go ahead and just stop here for now? We'll stop at bioterrorism. And then I'm going to get with Dave and try to come up with a more thorough presentation because I mean we only have a couple minutes left, and really dive down into some of our intravascular device infections and this chapter specifically. I don't know if you know. No, actually I do know there were a lot of infections that occurred with COVID. There was a significant increase in our CLABSIs, just nationwide. It's it's undeniable. So I think that having the opportunity to actually spend a bit more time to do a deeper dive into intravascular device infections would be really great. So I'm going to go ahead and stop the recording now. If you have any questions, feel free to put them in the chat and I can stay and answer them. Um, but if you don't, have a great rest of your week. And remember, we will not be meeting on Friday. So we've already had our 2 sessions to make up for last Friday and this week, Monday and today. So no meeting on Friday. And hopefully I will have figured out how to send a group email by then. Okay. Thank you so much.